Good morning. Hello, my name is Clara Dick, and I'm an associate member of the Institute for Healthy Living and Chronic Disease Prevention. And it is my pleasure to host today's webinar. A warm welcome to all our guests from across the country. I would like to begin that my office is situated on the traditional, ancestral, unceded territory of the Secwepemc Nation. I would also like to acknowledge that you are joining us today from many places near and far, and acknowledge the traditional owner and caretakers of the land. So a few housekeeping items before we get started. We do have closed captioning for today's webinar. To turn closed captioning off, select the Hide Caption button on the menu bar. You can move the caption box to a better place on your monitor by click and drag. Please do type questions or comments for the speaker into the chat box during the presentation, and questions will be read out at the end of the presentation. We love feedback for this event, so please complete the survey that will be emailed to you. Today's event is a partnership and research webinar supported by the Institute for Healthy Living and Chronic Disease Prevention at UBC Okanagan. So this week marks Hospice Palliative Care Week in Canada, and we are so pleased to recognize this important week alongside the Canadian Hospice Palliative Care Association and many other palliative-focused organizations across the country. Today's webinar is a part of our palliative-focused webinar series, which highlights cutting-edge Canadian research in palliative care. So this week's webinar is titled Medical Assistance in Dying and Hospice Palliative Care, Depictions in the Research Literature. It is my pleasure to introduce to you Dr. Jennifer Dorman, Assistant Professor, Faculty of Nursing, Memorial University of Newfoundland and Labrador. I will pass it over to you, Jennifer.
Great. Thank you, Clara, so much for that introduction. Yes, I'm Dr. Jennifer Dorman, and today I'm going to talk a little bit about medical assistance in dying and hospice palliative care, and just some of the things I've come across in the research literature in how we talk about these different approaches at the end of life. I want to start with a brief land acknowledgement. I was born and raised and did most of my schooling on the traditional territory of Treaty 7 in Alberta, and I am a recent transplant to Newfoundland. So now I am coming to you from just outside of St. John's, and I respect that I am on the territories of diverse Indigenous groups. These include the Beothuk, the Mi'kmaq, the Innu, and the Inuit of this province. So a little bit about what I'm thinking around today, what we can talk about in this particular presentation. I'm going to start by telling you a little bit about myself. I do recognize talking about MAiD and hospice palliative care, you can't be apolitical. We're all going to bring biases to this work. So I just want to give you a little bit of context on where I'm coming from as I do this research. I thought I'd start with some background context because, again, I don't know where everybody is from in this presentation in terms of audience members. So I'm going to give a little bit of background context about hospice palliative care and MAiD, just to make sure we're all on the same page. Then we'll take a look at MAiD and hospice palliative care in the research literature and a couple of the themes that became apparent as I was doing my literature review for my doctoral work. I'll talk about how maybe some of the things I saw in that literature review are still occurring in our current research that is out there. And then we'll talk about a few considerations for continuing to do research in this area. So the structure of this presentation is going to be drawn from the content from a lit review I published last year. As I said, I completed it as part of my doctoral work, which was looking at how hospice palliative care nurses experienced moral distress when their patients contemplated, chose, or completed MAiD. It is an open access article, so you should be able to find it. If you have difficulty, though, please don't hesitate in reaching out to me, and I'm happy to send it your way. And I've also included some examples from my doctoral research as we talk about the things that I'm seeing in the literature, just to show you how some of our discourse can play out in a more practical sense. So starting a little bit about me, I start a lot of these conversations with the caveat that I'm not a lawyer. I am going to be talking a little bit about the legislation around MAiD, and I will be describing things to the best of my understanding around them. But if you do have legal questions, I don't have the education to understand the nuance between all of it. I can do my best to answer, but I just want to be straightforward. You're getting my understanding of what is out there. But besides not being a lawyer, I have been a hospice palliative care nurse for almost 20 years. I have had my certification in palliative care basically since the second I was eligible to go after it. So again, happy National Hospice Palliative Care Week to those who are celebrating. That might give you an idea a little bit of where some of my biases lie, because I absolutely do love hospice palliative care and I love talking about end of life care. Um, so usually when I say I'm a hospice nurse, people do ask me, what is your position on MAiD? How do you feel about that? In general, I'm okay with MAiD being an option at the end of life. I think people should have that choice and they should be able to avail of it if they meet the eligibility criteria. I do struggle though a little bit with how we position MAiD and hospice palliative care. I do have some concerns about how hospice palliative care has been represented, not only in the arguments for advancing MAiD, but also kind of how we're talked about in general. So I do have a little bit of bias there as well, in how hospice palliative care is represented in general. So just to keep things in mind, I like to be transparent. You'll likely see some of my bias towards hospice palliative care come up in this presentation. But like I said, I recognize we all bring biases to this work. So a little bit about background, context, and definition. As I start to go through these, and these are going to be broad strokes, big overview of hospice palliative care and MAiD. As I go through them, you might start to notice a couple issues with concepts and definitions that we use, and I just want you to keep those in mind as we start to consider the relationship between hospice palliative care and MAiD in the research. So I'll start with hospice palliative care. Because it is Hospice Palliative Care Week, I like going first about that. Our modern ideas of hospice started in the 1960s in the UK with a lady named Dame Cicely Saunders. And while she was developing hospice, a Canadian physician, Balfour Mount, went over, learned all about it, and brought what he learned back to Canada and started our first palliative care unit in the 1970s. He actually coined the term palliative care. He wanted something that worked in both English and in French. And I believe he coined it from the Latin palliare, which means to cloak or cover, because in palliative care, we're not looking at curative things. We're not trying to fix underlying issues. We're trying to deal with the pain and symptoms that those issues cause, in sense, cloaking them so that people don't have to deal with them. So when we talk about palliative care and what we do, we focus on specialized pain and symptom management. It's a very holistic approach to care. We focus on quality of life, however the patient defines it, and we are pretty clear about that we neither prolong nor hasten death. And you might say, okay, so you're talking about hospice and you're talking about palliative care and you have hospice palliative care here on the slide. What's the difference between all of these? So when we talk about hospice specifically, we're looking at usually like a freestanding building or a place where palliative care is specifically provided in the last 3 to 6 months of a patient's life, depending on provincial regulations around who's eligible for hospice. Palliative care itself can take place in any setting. If we really want to get into the nitty-gritty, palliative care could really be started the second somebody is diagnosed with a life-limiting illness. We do know, though, that people tend to access palliative care later in their trajectories and often not as early as would be really beneficial for them as well. When we put hospice and palliative care together, we just call it hospice palliative care. So if somebody is talking about hospice palliative care, they're usually talking about palliative care in general. And so we talk about hospice palliative care and end of life. And one of the questions that became really apparent really fast when I was doing this work was, when does the end of life period begin? How long does it last? And if you think about it, if somebody said, hey, how long is end of life? Would you think about the last minutes, hours, or days of somebody's life? Might you expand that to weeks or months, maybe years? Would it start at the time of diagnosis of a life-limiting illness? And would it include something like grief and bereavement after a patient dies? So it became clear very early on that how this end-of-life continuum is conceptualized, that can influence our understanding of how MAiD and hospice palliative care are related to each other. Huey et al. Did a really good systematic analysis of the end-of-life period to see how it was defined in the research that's out there. And what was really interesting is really end of life depends on the authors that are talking about it and the criteria that they choose to define that end of life period. So you can see already there's maybe places where conceptual clarity would help a little bit because end of life is going to depend on the people who are talking about it in terms of how we think about it. So that's, like I said, broad strokes about hospice palliative care, and this will be a very brief overview of MAiD in Canada and how we got to where we are right now. And I'm really not even going to get into all the little provincial nuances and things that are going on. So again, broad strokes. MAiD itself, we can kind of trace back our modern ideas around MAiD to the 1990s. Sue Rodriguez in 1993 brought her case to the Supreme Court of Canada. She had ALS and she argued that she should have the right to an assisted death. At the time, the court ruled against her 5-4 and said they had a duty to uphold the sanctity of life and security of the person. Sue Rodriguez herself did ultimately die with an assisted death in 1994. But that's kind of set the groundwork for how we got to Carter v. Canada in 2015. So Carter v. Canada was brought on behalf of Kay Carter and Gloria Taylor, both who had died prior to the case being heard. And they argued the same thing, that they should have had access to a medically assisted death. This time, unlike with Sue Rodriguez, the court ruled unanimously 9-0 that yes, they couldn't decide for people what their quality of life was like and when life should end, and that people should have the right to decide when their deaths should occur. So once Carter v. Canada kind of was ruled on, they gave the government 12 months to figure out legislation around what MAiD was going to look like. Took a little bit closer to 16 months instead. And in June of 2016, we got Bill C-4, which laid out the groundwork for MAiD in Canada. It included things like eligibility criteria. It talked about how healthcare professionals, if they followed what was in the bill, could not be found criminally responsible for counseling people to end their lives. And we'll talk a little bit about eligibility criteria in a slide or two. There were some provincial challenges, and we ended up with Bill C-7 in 2021, which made some adjustments to that original eligibility criteria, which again, I'll talk about in a couple slides. And kind of next on the horizon for us, it's not here yet, but MAiD where mental disorder is the sole underlying medical condition. We were supposed to have kind of a decision on it in 2024, but the government asked for more time to review it. So that's been pushed back to March of next year, when we should know whether, again, the eligibility criteria will be readjusted to potentially include mental disorder as the sole underlying medical condition when somebody is applying or to be found eligible for MAiD. So the eligibility criteria, I'm not going to go through all of it, but I am going to focus on the middle section here, which is really important. One of the eligibility criteria is that a patient has a grievous and irremediable medical condition. So that means they have a serious and incurable illness, disease, or disability. The patient is in an advanced state of irreversible decline in capability. Their illness, disease, disability, or state of decline causes them enduring physical or psychological suffering that is intolerable to the patient and can't be relieved under conditions or with treatment that the patient considers acceptable. So the original eligibility criteria as set out in Bill C-14 also included a criterion around reasonably foreseeable death. And that was one of the things that was challenged that led to Bill C-7. There was an argument that how do we decide what a reasonably foreseeable death is? There was concern that in limiting MAiD to people with reasonably foreseeable deaths, we weren't following the spirit of the Carter v. Canada ruling, which didn't put any limitations on who could apply for MAiD in that sense. So Government of Canada redid the eligibility criteria. They took out that criterion of reasonably foreseeable death, and we kind of ended up with this two-track system of MAiD. So we still call track one the reasonably foreseeable death track. And this is still for people who have diagnoses that are going to lead to their death, usually in like months or years, maybe a bit longer, depending on the diagnosis. They still need to meet all the other criteria for MAiD to be found eligible. And they do have the option now, as a Bill C7, to sign a waiver of final consent. So typically, when you're doing a MAiD provision, you are required to get consent from the patient right before administration starts, right before that provision starts. If there is concern that somebody is going to lose capacity to be able to consent, then the waiver of final consent, if it's signed, if the person can no longer consent, you can still go ahead with MAiD unless they're like, really pulling away or really indicating that they don't want to go forward. In terms of track two, so now that this reasonably foreseeable death criterion is gone, we have this other track for patients who don't meet that criteria of like having an underlying almost like terminal illness. This would be more along the lines of maybe people with chronic illnesses that aren't going to necessarily lead to their death, or they could have a disability or an injury, all of which can still cause intolerable suffering. So again, with this track, they still need to meet the criteria laid out for MAiD. There are a few extra safeguards involved as well, and they have a bit longer of a reflection period between the time their second assessor comes and assesses them for MAiD and the time that MAiD provision can happen. Having said that, even though there are these reflection periods, they can be shortened if the assessors are in agreement that somebody is going to lose capacity before they have the option to proceed with that MAiD provision. So some relationships that I'll talk about. There were 5 kind of big things that came out of the literature when I was doing this literature review. And for this particular presentation, I'm going to focus on 3 of them specifically. I'm going to look at MAiD as being considered part of palliative care. I will look at the literature and the findings where MAiD was considered as something separate from palliative care. And then I'll also consider the relationship between MAiD, hospice palliative care, and suffering, and how our understandings of suffering can affect our understanding of the relationship between MAiD and hospice palliative care. So some general findings just before I get into some more specific things. First off, there was a lack of specificity in the research literature in terms of defining concepts other than MAiD. And I do wonder if some of that lack of specificity may have led to uncertainty in how MAiD fit into end-of-life care, because it wasn't specifically with hospice palliative care and how it was defined. There wasn't a consensus on what it was. There wasn't a specific definition that people were using. So when we're not sure exactly what hospice palliative care encompasses, it can be difficult to figure out if MAiD is any part of that in there as well. Confusion around these terms, again, I don't know if it was due to maybe a lack of end-of-life care research in general, or maybe people just really haven't delved into it. But that conceptual clarity did make it difficult when we were considering what the relationship between MAiD and hospice palliative care might look like. Also, whenever MAiD was talked about in the research literature, it was very much talked about in the context of Bill C14 and then later Bill C7. And all the papers were very specific about talking about eligibility criteria, etc. But fewer papers really delved into the tenets or goals of hospice palliative care as a way of contrasting or comparing these end-of-life approaches. Many papers didn't even really examine the moral or ethical differences around MAiD and hospice palliative care. And I'll talk a little bit about that in a couple slides as well. Regarding the effects of MAiD legislation on hospice palliative care, there were some initial concerns raised that if we are focusing on MAiD, that financial or economic support for hospice palliative care might be diverted to MAiD instead, and that MAiD will get this financial support, education, awareness, all those kind of things. I got to say, I haven't seen any financial support being diverted from hospice palliative care. On the flip side of that, though, some people felt that, if MAiD is getting all this attention, maybe that will actually be good for hospice palliative care, that we'll get more eyes on us, people will be more aware of us, they'll be more informed about what we do, and then maybe we can use that to build on going forward. There were also some concerns raised about MAiD becoming the default option if hospice palliative care was difficult to access as well. So those were just some general things that came out of the literature. So MAiD as part of hospice palliative care. This is a very simplified statement, my first point on this slide, but this is kind of what we were seeing in the literature when thinking about how MAiD and hospice palliative care related to each other. And there was this sentiment of, if MAiD ends up resulting in death and hospice palliative care ends up resulting in death, then MAiD and hospice palliative care are the same thing. So given that both these interventions resulted in patient death, MAiD was often subsumed as part of palliative care. And even for this, you could replace death in this equation with relieve suffering. Both these things relieve suffering, so that means both these things are equivalent to each other. If philosophical underpinnings of hospice palliative care were addressed when thinking about if MAiD and hospice palliative care were similar, typically the focus was more on whether MAiD and hospice palliative care could be read as ethically and morally similar practices in the context of the legal ruling, because both had intended outcomes of relieving suffering at the end of life. The exploration of the philosophical underpinnings and moral and ethical concerns really didn't go anywhere beyond that when we were seeing MAiD equated with hospice palliative care. From a public perspective, typically what the literature was finding was that the general public viewed MAiD and hospice palliative care as compatible because they didn't really understand the philosophies that are underlying hospice palliative care. They didn't really do a deep dive into what was going on in terms of intended outcomes of each practice. And some authors did raise concerns around, the blurring of hospice palliative care and MAiD goals. And they said, if we're blurring these goals, then it's really easy for people to take another step and perceive, hospice palliative care as similar to MAiD. They could perceive hospice palliative care as a process that hastens death. And I do point out, and I'm sure this is not new to anybody who practices in palliative care, we already know people have misconceptions about what we do. There are people out there that think palliative care hastens death, right? There are people out there who don't even know that we exist. So it was a real concern that in not differentiating these aspects, not differentiating MAiD and hospice palliative care, we are going to continue to get this conflation of the two together. And this wasn't just limited to the public. It could be a perspective held by healthcare providers as well. Usually because they felt, hospice palliative care is perceived as this domain of death and dying. So anything related to death and dying should go into hospice palliative care. And I think part of that too comes from, at least from the healthcare provider side of things, we are a specialized practice. There's not necessarily a lot of education around hospice palliative care in training, whether undergraduate or other areas. I know personally, I didn't really learn a ton about hospice palliative care until I was at the bedside in hospice, where I really got to delve into things. Prior to that, my hospice training or palliative care knowledge was limited to like a paragraph at the end of a textbook chapter, right? It was like, oh, and here's all this pathophysiology and supportive care and everything for this one disease. And then, you know what? Oh, yeah, also here's palliative care if you need something else, and none of this other stuff works. So we were very kind of like shoehorned in at the end. So I think for hospice palliative care providers, it can be difficult when we're talking with other healthcare providers to explain exactly where we're coming from and what we do. There's also this idea that, if we were talking about MAiD as part of hospice palliative care, MAiD was more likely to be portrayed as one more intervention that we could try if everything else we tried was not able to relieve suffering, or if it was ineffective. Kind of another tool in the tool belt is how I heard it described. And then patients themselves, they had some mixed views on the relationship between MAiD and palliative care. And when we were looking at MAiD as part of hospice palliative care, some terminally ill patients actually viewed MAiD as an extension of good hospice palliative care. They felt that, kind of similar to what we were saying about another tool in the tool belt, I can be supported with palliative care, and if it's not effective enough, I've still got this one other thing I can do to relieve my suffering. I thought I would throw out as well, because this was interesting. There was a survey done kind of within the two years of MAiD being legalized, and it showed that both the public and healthcare professionals really supported high quality palliative care or end of life care. But the way they prioritized it was a little bit different. So healthcare professionals tended to prioritize hospice palliative care as kind of the preferred approach of choice, whereas the public prioritized MAiD. So we still see a little bit of a divide there in how the public and healthcare professionals think about MAiD and hospice palliative care. And then there were just a couple general arguments around what happens when we integrate MAiD and hospice palliative care. And one was one finding that people suggested was that, if we consider MAiD part of hospice palliative care, this might actually result in patients being less likely to feel abandoned by the healthcare system, especially when we're looking at areas where, somebody needs to be discharged or have a forced transfer from hospice in order to pursue MAiD, or having to decide to decline MAiD so they can stay in hospice palliative care. And so a lot of these papers did note that, so allowing MAiD in hospice, yes, it could support patient autonomy and non-abandonment, but there's still this ethical and practical tension around our mandate of neither prolonging nor hastening death and having MAiD occur in palliative care spaces. So while they said, yes, there are some benefits to this, there are still some other ethical tensions that need more exploration if this is going to continue to be the process moving forward. So just a couple examples here, and I pulled these from my doctoral research when I was speaking with some hospice palliative care nurses. So the first quote kind of harkens back to that another tool in the tool belt that I heard expressed. So a lot of times the nurses and the patients were both referring to MAiD as something they could keep in their back pocket or as like a backup plan. So again, it's that one more thing we can do as part of palliative care if the rest of the palliative care interventions don't work. The second quote I have here is just kind of an example of what happens when there isn't clarity about the differences between MAiD and palliative care, and what happens when patients conflate the two as being very, very similar or the same. And this was a nurse that I spoke to in a hospice as well. And she said the first patient who had provision offsite, so MAiD provision, they left the hospice to go have it done. The family was very open with other families about what was happening, and they had 4 or 5 residents who were terrified that they were going to be next for MAiD. One of them broke down because he was terrified and felt afraid to tell anyone on the hospice team, too afraid of what we might do to him if he spoke out. So you can see that without that conceptual clarity, there can be some real terrible issues that arise because of this that can lead to suffering for patients and families because they don't understand that difference between MAiD and hospice palliative care. They don't understand that MAiD is something they need to ask for, that there is eligibility criteria they have to meet. So again, really important that even if we are considering MAiD as part of palliative care, we need to be very clear about what MAiD and palliative care are. So in terms of MAiD being seen as something separate from hospice palliative care, there's 2 kinds of things that came up in the literature. There were several articles that were also clear that MAiD was not part of hospice palliative care at all, and that they were fundamentally different practices. Having said that, though, a lot of the papers that made that distinction and said, no, these are 2 separate things, they didn't really do any look at nuances in the philosophy or intended outcomes as part of why they were saying they were separate issues. It was almost like, nope, they are completely separate. We don't have to examine this anymore, which was kind of interesting because you'd really want to still, again, be able to separate out why are these 2 practices different and why should MAiD be separate from palliative care. Several authors were also really clear around saying, if these are distinct services, this is why. So a few of them said hospice palliative care, we distinguish it from MAiD by being, this really holistic approach to care. We're focused on holistic pain and symptom management. And all of this is taking place in the context of promoting quality of life at the end of life and neither prolonging nor hastening nor death. So they were very clear about how palliative care could be read differently than MAiD and why the 2 of them didn't really fit together. A couple authors also suggested that even though these are separate, hospice palliative care and MAiD could support terminally ill patients while they were contemplating maybe completing MAiD procedure, just as like palliative care supporting them through the process. So it would be, you have your palliative care support, we're supporting you with end of life care needs, pain and symptom management, whatever that looks like for the patient. And if they still want to do this MAiD piece, somebody who's not the hospice team is going to come talk about the MAiD. they're going to do the eligibility assessments. If the patient chooses to, if they're found eligible and they choose to pursue MAiD, that's going to be done, but hospice palliative care doesn't have anything to do with that MAiD piece. We'll support you. You can have that MAiD piece, but then we'll come back in at the end for the bereavement and grief pieces that occur after a MAiD death. And this wasn't a view that was necessarily only held by healthcare professionals. Some terminally ill patients also held it as well. They viewed MAiD as a separate procedure. Again, they were like, support us with palliative care while we're getting assessed and figuring out what's going on. But we do recognize that MAiD is something different and it's not necessarily part of the palliative care sphere of practice. A potential issue that was raised as well in thinking about the relationship between MAiD and hospice palliative care and how they might be a little bit more separate. A few authors raised the point that, you know, the removal of this foreseeable death clause from Bill C7 that might result in decreased integration of MAiD and hospice palliative care because of this two-track system. So what they were suggesting was track one, because they're still, you know, closer to end of life, prognosis is shorter, they're still likely getting that palliative care piece. Track two was going to be a little bit different, where because that we now have the second track that people have longer prognoses that in general might make them ineligible for palliative care or to be followed by a palliative care team, that kind of makes MAiD and palliative care very much more separate. So it will be very, very interesting to see how, as we learn more about track two and see how it's playing out, it'll be interesting to see if there is some kind of relationship there between track two MAiD and hospice palliative care, and maybe what kind of gaps are showing up as well. So a couple of examples where MAiD is separate from hospice palliative care. Both of these are position statements from palliative care organizations. The first is from the Canadian Hospice Palliative Care Association. It's their updated position statement on MAiD. And they explicitly say MAiD is not part of palliative care. Again, it's more this palliative care can provide support around MAiD before and after, but it's not part of that MAiD piece. Also, the Canadian Palliative Care Nursing Association has a good statement about MAiD and palliative care. And while they're not as explicit about that relationship, they do talk about ways that palliative care nurses can use their training and skills and expertise to support family throughout the end-of-life care process, support them if they are considering MAiD, how our expertise would be really well positioned to help in the development of MAiD policies, especially when MAiD is occurring in palliative care spaces. And that, again, too, we're really well positioned as palliative care nurses to ensure open, curious, and respectful dialogue about varying viewpoints on MAiD, whether that's from our patients and families or whether that's from our colleagues and other healthcare professionals that we're working with. So how does suffering change how we think about this relationship between MAiD and hospice palliative care? And a couple of the questions that came up were, how do we deal with suffering at the end of life? And what types of suffering are driving MAiD requests? And is it what we expected when MAiD was first legalized? So there was concern, especially when we were talking about, you know, right before MAiD was legalized, before Carter v. Canada, there was concern that hospice palliative care interventions were insufficient in managing suffering at the end of life. And that was used to further argue MAiD as an end-of-life care option. And especially at that time, the media discourse around MAiD really perpetuated a narrative that was focused on very, very intolerable, immense physical suffering at the end of life, and really the importance of autonomy for individuals to make choices about how they died. Researchers who were doing this media analysis really noted that journalists didn't differentiate hospice palliative care interventions from MAiD, and that was if hospice palliative care was mentioned at all in the media articles. I was actually at the KMAP conference this weekend, and there was some discussion around how MAiD is being portrayed in the media these days as well. And what I was hearing there, the general consensus was that across Canada, MAiD is getting more of a negative slant these days, especially with consideration of mental disorder as the sole underlying medical condition. But having said that, in Quebec, the media is actually much more positive around MAiD, almost to the point of romanticizing it and making it look like this fabulous end of life care option. And so we do need to be aware of that, because those media perspectives are going to seep into our work. And we do need to be aware of the biases that we might start bringing into our assessments that we're doing. So that was around the media. And then there was also a disconnect around the suffering that was expected to propel MAiD requests versus what we're actually starting to see now that we've had MAiD for a while. During the arguments for legislation of MAiD, a lot of proponents for MAiD focused on pain and physical suffering, noting that hospice palliative care can't completely relieve all types of suffering. So that's why we need MAiD as an option. If there was discussion about existential suffering, it was largely confined to discussions of neurodegenerative illnesses and seen as something occurring outside the scope of hospice palliative care. So that's what they were worried about or felt that most MAiD requests would come from. But what we actually started to see once MAiD started happening was that things like physical suffering, so intractable pain and symptoms, those were more associated with palliative sedation, which is a palliative intervention, while existential suffering or things like loss of control, loss of autonomy, worry about being a burden or fear of future suffering, and concerns about dignity at the end of life, those kind of concerns were much more associated with the MAiD requests that were being made. There was also some discussion in terms of suffering and sociodemographic factors associated with MAiD requests. And there was some concern in the literature about people accessing MAiD because they didn't have access to things like good health care, good hospice palliative care, that they were more vulnerable. And we're starting to dig a little bit more into that. I saw in the 6th annual report on MAiD that came out in October, they're really starting to pick apart those social determinant of health pieces to see if there's any kind of influence going on there. But what some of the research is showing now that typically people who are requesting MAiD, they're a very, very similar demographic to people who are requesting palliative care. So these are people who are well educated, they're wealthier, they're white, they're usually dying of cancer. So there is a suggestion that maybe vulnerability, maybe these issues aren't driving MAiD requests so much. However, on the flip side of that, there are also questions about, are vulnerable people even able to access things like MAiD and hospice palliative care? And I think it'll be interesting to see research coming out around that. So what are we seeing in recent research? Keeping all of that in mind, this is just a quick little tour of some recent articles that I pulled that talk about both MAiD and palliative care in some kind of capacity. I want to be very clear, this is not a criticism of the articles or the authors involved in them, and I do recognize that the relationship between MAiD and hospice palliative care aren't necessarily the main topic of focus for each of these. But since they mentioned MAiD and palliative care, I thought I would just take a look and see how both are being talked about. So in this first article here, Close et al., it is a review of regulatory practice standards and guidance documents for physicians around MAiD. So looking at these documents that give practice guidance, right, around how physicians should approach MAiD requests. And it does discuss palliative care in the context of MAiD legislation, but then there's really no other discussion about palliative care or a definition or anything like that. And granted, I get that this is a review of these medical regulatory documents specifically about MAiD, although I would assume the documents probably talk somewhere about palliative care or refer the physicians to other documents in order to support palliative questions and approaches. I just find it interesting that it's not really brought up at all in this paper. And then the second one here, Henderson et al. This is Nurses' Perceptions of Practice Supports Related to Medical Assistance in Dying. They do mention palliative care briefly in their introduction, but they don't really take that into their consideration of suggested practice supports for these nurses. They include things like education, therapeutic communication skills, and debriefing. And just thinking about the CPCNA's statement of saying, hospice nurses are really well positioned to do these things, I think this is an area where some discussion around palliative care could have been included in the recommendations they made. And I want to say these are good recommendations. I made very similar recommendations in my doctoral work for hospice nurses around education, debriefing, those kinds of things, because they are necessary to support nurses who are practicing in palliative care and for nurses where MAiD is happening in palliative spaces. So again, just interesting that they did bring up palliative care, but then it didn't really extend through to their discussion at all of how best to support these nurses. And I just thought this was interesting that both these articles were published in two different palliative care journals, and they really don't talk about palliative care at all. So not to say they're not within the scope of the journals. I'm sure the journal's scope is a little bit broader, looking at end-of-life care more generally. I just thought it was kind of interesting that they both have palliative in their titles, and yet the articles don't really touch on palliative care at all. Because I'm an equal opportunity criticizer, I've included my own article here as well, my lit review, just to kind of give another example. So yes, I do have a substantial paragraph on hospice palliative care and a definition about it and what it is. But I knew going into writing this that I was going to be looking at the relationship between MAiD and hospice palliative care. So I wanted to be very clear about that. And it was, I feel like, a bit of a reaction to reading a bunch of articles where they talked over and over about MAiD and then barely mentioned palliative care. So I wanted to make sure we were getting our dues as palliative care providers. Having said that, the two substantial paragraphs that come before this one are all devoted to MAiD. So I am as guilty as anybody else of, prioritizing and maybe privileging MAiD and MAiD discussion over hospice palliative care. Again, these are things that are coming up in our discourse, and I am not immune to them. So I just wanted to throw that out there because I'm also guilty of doing the things that I'm pointing out. Lastly, Booker et al. This is a really good article. It's about advances in end-of-life care in Canada, implications for oncology nursing. They look specifically at palliative care, advanced care planning, and MAiD. They do a phenomenal job of going through what palliative care is. They talk about palliative care misconceptions. They talk about underlying philosophy in palliative care. They talk about MAiD and how that relationship has changed with palliative care. They talk about suffering and how that affects how we see those things. So kind of all the things I've already pointed out in this presentation, this paper is doing really, really well. So definitely recommend go take a look at it just to have more of a physical example of some of the things I've been talking about. So what are we seeing in recent research? Just kind of like an overall thing. We're still seeing similar things in the research. MAiD is the focus. Palliative care might be brought up, but there's little to no discussion of what palliative care is. There might be some discussion of underpinning philosophies and suffering, but not a lot. The MAiD definitions themselves in more recent publications, they're not as extensive as earlier ones, and I think that's understandable. We are more familiar with what MAiD is and what it isn't, and I think all the previous research is really good at pointing out, we can build on that, what MAiD is. I wonder, though, because we're getting more familiar with MAiD, is that the reason that we didn't really talk about palliative care or define it in the other research as well? At the time that research was coming out, palliative care had been in Canada for 40 plus years. It's 50 plus years now. So I do wonder if there is some kind of assumption that professionals or researchers have that we all know what palliative care is because it's been around for so long. But as MAiD and palliative care continue to work together, as MAiD continues to be provided in these palliative care spaces, and sometimes be provided by palliative care providers, how do we understand palliative care knowing all of that? Again, this isn't a comment on the authors or anything like that. I do feel like this is more of an issue of potentially our research culture and more broadly how we talk about death and dying more generally, including in places like the media, right? All of those discourses are going to affect how we talk about MAiD and hospice palliative care. So just a couple things moving forward, because I am cognizant of time. Just a couple recommendations, and I don't think I'm reinventing the wheel here. I think these are some simple steps we can take to ensure some more conceptual clarity and really good continued exploration of MAiD and hospice palliative care. So again, conceptual clarity about palliative care, more discussion about the changing ideas around how MAiD and palliative care exist alongside one another. would be really good. We're starting to see some of that with like the CHPCA and CPCNA statements that were put out, the position statements. Maybe we can consider some more systematic reviews or concept analyses, just so we have that clarity when we're talking about concepts or messaging or frameworks or policies and procedures. I also recognize that MAiD and hospice palliative care, they're going to continue to evolve and will likely affect each other. So we need to keep looking at how that relationship is changing. So critical analysis and moral and ethical consideration of that intersection between MAiD and hospice palliative care, given our changing legislative landscape, is really going to help drive some of that discussion around this change in practice. And again, here I point to, we're going to have lots of track 2 research coming out, and I'm sure that's going to change how we think about MAiD and palliative care. If MD SUMC MAiD comes out as well, that's going to have a huge effect on how we think about palliative care and MAiD also. So keeping those things in mind is going to help us do really good, conceptually clear research going forward. I do have some references. If you want them, I'm happy to send them. And thank you so much for listening to my presentation, and I am happy to take any questions.
Thank you, Jennifer. Wow, that was amazing. What a great overview and kind of update in where we are across Canada in terms of MAiD and hospice palliative care. So there are some questions in the chat box. If you do have any more questions, please do put them there and we'll read them out. So let's get started with those. There's some great comments. Thank you, everybody. Very engaged. First comment, I thought that to palliate meant to improve or feel better, like for a symptom. That's interesting that palliate Latin means cloak or cover.
Mhm.
Yeah, that's really great. The next question is about eligibility. Wondering about eligibility for MAiD. The person meets the federal eligibility and whether one can be eligible in another province that currently does direct billing.
Honestly, I would have to pass that question to a physician or provider who knows about direct billing. I can't answer that as I'm not a MAiD provider.
Sure.
So sorry, I wish I had a better answer for you.
Yeah, no, that's okay. I know this question is from British Columbia, so I know that we have some great MAiD teams on each health authority here. They'd be the person to reach out to then.
Mhm.
The next question is, who would do the MAiD piece if it was not the hospice team?
So that's a good question, and it is going to vary provincially in terms of how they have things set up.
Okay.
I am working here in Newfoundland, but I was most familiar with the setup in Alberta, so I can talk a little bit about that as an example. So in Alberta, we had something called the MAiD Care Coordination Service, and we could either refer patients to it if they had questions about MAiD. Patients could self-refer. If they called 811 and had questions about MAiD, 811 could get them set up. And the MAiD Care Coordination Service could take over that piece. So in some of the hospices I worked in, if somebody had a MAiD request, it wasn't anybody on the hospice team that did the assessments. The Care Coordination Service actually sent physicians or NPs to come do that eligibility assessment piece. So at least in Alberta, there was definitely a bit of a separation there between like the hospice staff and the MAiD service as well.
Yeah. Yeah, that's a good question. And I can say that that's what happens in British Columbia as well. Yeah. Okay. This is an interesting question about statistics. The one question that I do have is, are there any statistical information related to how many individuals have completed the MAiD application process as a backup plan in case the course of their illness is not what they want or wish?
Oh, that is a good question. I don't know if there's statistics specifically looking at if it's kept as a backup plan. There are definitely statistics out there, though, about people who have applied for MAiD and then don't necessarily proceed with it. Like they found eligible, but they never end up at the provision
Right.
point. And that would be like the federal stats there, the 6th annual report on medical assistance
Okay.
and dying.
Out
Yeah.
in October. Um, In looking at those stats, do you know if there was any around who had applied for MAiD and then who had a natural death before their MAiD date came up?
That would also be in those stats
Yeah,
as well. Yeah.
yeah. Awesome. Okay. So this comment is really really important that we address. I'm into the webinar and find it is focusing more on healthcare workers. If this was meant for the general public and those who wish to use MAiD, it would be better to tell how exactly MAiD works, not the laws, i.e., where does this occur? Is the person drowned before they inject medication that ends their life? So thank you so much for this comment. And what I'm seeing is that this really highlights some of your work, Jennifer, in terms of really clarifying, the difference between MAiD and hospice palliative care. And when we don't know what's happening, there's a lot of fear around that. Do you have any comments for this?
Yeah, so definitely I think there is a gap there. People hear about MAiD, the public hears about it, but they
Yeah.
don't have necessarily understanding of, like the commenter said, like of the process and what that looks like.
Mhm.
And I think one of the things going forward that we really need to do is have a lot more public engagement around that. Because again, I've heard there are stories out there about what happens when you go for MAiD, and that can be like what actually happens to your body, and those misconceptions aren't necessarily what happens, right? So yeah, I think it would be really worthwhile, honestly, and I would be happy to do another session about this. I could talk about what that MAiD process looks like in, less of a healthcare provider lens, because I think it is important that people understand exactly what that process looks like.
Yeah, yeah.
Yeah.
Thank you for that offer. Let's connect on that later.
Okay.
And I'll pop my email in the chat if anybody wants to reach out about specifics around that, because those are really big questions. And how do you think that the media's portrayal of MAiD has influenced comments like this?
Yeah, that's also a really good question. I think it's hard again because media tends to sensationalize a lot of things, and they don't necessarily go into things like the misconceptions about MAiD or what it is. And like I said too, they don't talk about what hospice palliative care is at all when they're talking about MAiD. And I think it's really easy, especially in the age of social media. You hear clips and little things that aren't necessarily backed up by any research anywhere. And it's really, really easy to fall into this trap of misinformation about what's out there.
Mhm.
So could the media be doing a better job? Absolutely. But I also think as researchers, part of our engagement and getting knowledge back to people is to engage with the public and make sure they are getting appropriate, accurate information about what's going on.
Yeah. Yeah, and that's that knowledge translation piece. Like, sure, we do
Mhm.
all this work and we know all these things, but that's like we're yelling in a closet. So how can we open the closet door and step out into public? Um, so the next comment is, have there been any quantitative, qualitative interviews with hospice end-of-life social workers about some of their experiences?
That is a good question. I believe there are a few studies out there starting to look at social work. Definitely not in the numbers we've seen around studies interviewing, like, say, physicians or nurses. Like
Yeah.
allied health, unfortunately, is still a bit of a gap in the research. I
Mhm.
think there are a couple out there. I don't have any authors coming to mind right away, but if you do look it up, I believe there's a couple that have started investigating social worker experiences around
Um,
me. Yeah,
if you remember those later, feel free to send them to me. I'll take a
absolutely.
little dig as well. What great. And do you know what I love about this question is that it brings up the idea that hospice palliative care is a team sport,
Hmm.
and it takes everybody. And when we have some more complexity with medical assistance in dying, let me tell you, social workers are right there.
Absolutely. Yeah.
Comment, fantastic presentation and speaker, great content. Thank you,
Thank you.
Jennifer. Is made available to financially limited persons.
I can't see why it wouldn't be. There's nothing in the eligibility criteria around finances. I think for people who might have financial difficulties, it might be more of an issue of access rather than anything else. But no, financial difficulties shouldn't preclude you from investigating MAiD as an option.
Yeah, yeah. And those kind of questions are great because once we clear them up, it brings down a barrier, and maybe it alleviates some of the potential stigma. Yeah.
Mhm.
Again, another question, or comment. Thank you for an informative presentation. Well done.
Thank you.
Yeah. Thank you for the presentation. I am in rural BC. I'm wondering if there are more people choosing MAiD in locations where a hospice palliative house is unavailable.
Yeah, and that's a good question. And that's one of those things we're not entirely sure about yet. There have been concerns around that. Yeah, if people can't access good palliative care, that MAiD might be the next step, right? And we really don't want to see that happening, and that shouldn't be happening ideally. I don't know if there's any specific data that speaks to that. Definitely within the federal data that's collected, they do look at if somebody has had access to palliative care, if they've used it, if they've chosen not to use palliative care. But I don't know that there's necessarily any looking at how that relates to location in terms of what programs are available. Definitely
Great.
a gap in the data, but I think it's something that is worthwhile investigating, definitely.
Yeah. Yeah. And that also speaks to the greater picture of access to healthcare in Canada, I think.
Hmm. Hmm.
Lots of great comments here. Can 811 connect a resident who requests to the MAiD care coordination team in BC? I didn't realize. Good to know. I believe that 811 in BC will connect you with a MAiD coordination team. Also, in each health authorities, there's 5 health authorities in BC. Each website will definitely have all the resources needed. Okay, next question. I would like to know actual process of MAiD, applying for, how it is done, etc. Yeah. So we did touch base on this a little bit earlier, didn't we, in terms of having a coordination center? That's out west, but curious, um, out east.
Yeah, so I'm still learning the process out here, to be honest. I do know that if you look up MAiD on NLHS, they do have coordinators or kind of people to connect you with each health region that's out here or health zone that we have. And so you can reach out to them by email and they will follow up with you to, either arrange a discussion about MAiD or, answer questions, those kinds of things. I'm not sure if you can call 811 here and be connected with them. I honestly don't know, but I know for sure that people can just, yeah, email them for sure and they get back to you very, very quickly. So,
Right. And
yeah.
in terms of, so I always, with the nursing background, I always go into practicalities. They can walk you through step by step what it looks like in terms of what medications are given, in what order, what the effects are, and why they're using those.
Absolutely. Yes.
Yeah. And then also the before care and after care.
Hmm.
Yeah. Okay, and another comment, I do have some of that experience that we are speaking to. There are financial barriers that I can speak to. Okay, yeah. Thank you for that, Justin. And there's looks like a website here shared with everybody. Um, the next comment, we're heading into the last 2 minutes, so I'll just read the next couple comments and then offer it if you have any final words, Jennifer. Wonderful presentation. Did you see anything research about new Canadians accessing palliative care or MAiD?
Yeah, I have not seen anything personally. That's not to say there's nothing out there. I don't know of anything being published within the last year or so around that. But again, I think that is another gap that we are missing right now in our data and would be very much worthwhile looking into. Yeah.
Yeah, looking at the health disparities of
Hmm.
immigrants to Canada. Yeah. Very informative presentation. Thank you. Great presentation, Dr. Dorman. I'm heading into another meeting. Take care.
You,
Thank you. And with a couple minutes, do you have any last little nuggets that you'd like to share with us?
I mean, nothing that's springing to mind right away or anything, but honestly, please do reach out. I included my email as part of the presentation. If you do have questions about MAiD, I'm happy to answer them. And if I don't know the answer, I can at least point you in the right direction to people who can probably answer them for you. And absolutely, I really appreciate the feedback of focusing more on the actual process of MAiD and what that looks like. And we'll definitely consider that for future presentations around this information. So thank you so much for that feedback.
Yeah, thank you, Jennifer. And I do want to just acknowledge everybody's braveness in showing up to these and asking the good questions, the hard questions, all the comments. That's what makes this so rich and this discussion so rich. So thank you. And thank you everybody for attending today's webinar. You will receive an email with a link to an online evaluation form. And we welcome everybody's feedback and suggestions for planning events in the future. So thank you and have a great day.